Hello, I'm Dr. Rae-Grant, Director of Education for the Mellen Center for Multiple Sclerosis and Research. We are doing MS Highlights today, a report from the ACTRIMS meeting in Boston, which was held in September of 2014. I'm delighted to have a distinguished panel with me, both from the Cleveland Clinic and from the Mayo Clinic. Dr. Robert Fox, Dr. Alissa Willis, and Dr. Lael Stone, all from the Mellen Center for Multiple Sclerosis, and all of whom do clinical and research work. They also have Dr. Dean Wingerchuk from Mayo Scottsdale, who also does research and clinical work. So we'll be talking about a variety of topics in multiple sclerosis and related to disorders today.
Now I would like to present some of the abstracts that reviewed progressive MS and progressive disability. The first I would like to discuss was presented by Dr. Tintoré and her colleagues from Barcelona. They followed 1,000 patients with clinically isolated syndrome, or a first attack, and they looked at predictors of future disability, which they defined as an expanded disability status of 3.0, which indicates moderate disability. What they found is that predictors of future disability included oligoclonal bands on spinal fluid, incomplete clinical recovery from that first attack, and new lesions over the first year. All of these increased the risk of future disability, which probably was not very surprising. What was a little surprising, though, was that neither sex nor age were predictors of progressive disability. We often think of older patients having a higher risk of progressive disability, but in this study, following 1,000 patients, older and younger patients had the same risk of progressive disability. Also, very importantly, they found that treatment before the second relapse was protective of future disability. One of the questions in the field has been whether starting treatment at that very first attack, the clinically isolated syndrome stage, is indeed beneficial over waiting until the second, the clinically defined relapsing MS relapse. So whether that very early treatment was beneficial over just regular early, which would be when that second attack occurred. And what they found was indeed treatment before the second relapse was indeed protective of future disability. So this provides evidence that treatment early, even before that second attack, can prevent or decrease the risk of the development of disability. And this adds evidence regarding the importance of monitoring MRIs as well. So monitoring MRIs for new lesions to identify patients who are at increased risk for future disability. Next, Dr. Lubetsky presented work from her laboratory that was looking at the factors that led to remyelination. Specifically, her laboratory looked at the chemical factors that activated and recruited myelin repair cells, or oligodendrocytes, which live within the brain and reside there and become activated during periods of demyelination. She identified some factors that were upregulated after demyelination and stimulated the migration of the myelin-producing oligodendrocytes into areas of demyelination. She also identified other factors that were found to inhibit the migration of myelin-producing cells. By modulating the recruitment of oligodendrocytes, by increasing the factors that stimulated the migration and trying to inhibit the factors that inhibited migration, they could influence the remyelination in their animal models. So these studies provided a deeper understanding of what leads to remyelination, with the hope that therapies that can better stimulate oligodendrocytes to both activate and migrate towards areas of demyelination may eventually improve remyelination and eventual repair in patients who have had damage, like those in multiple sclerosis. Dr. Kearney from the London Imaging Group evaluated the association between spinal cord imaging and progressive MS. Some of the origins of this is because of the dissociation of the number of lesions on brain MRI and progressive disability, in that there isn't a strong correlation between brain MRI lesion load and disability in patients. So they turned their attention to spinal cord and evaluated what factors in the spinal cord imaging were associated with progressive disability. And what they found was progressive MS was associated with a higher number of focal lesions within the spinal cord, larger focal lesions within the spinal cord, more extensive gray matter involvement of the lesions within the spinal cord, and also more frequent diffuse abnormalities, this sort of hazy increased signal that is often seen throughout the spinal cord, but isn't quite focal lesions, but also doesn't look like normal, typical tissue as well. Important caveat to that study was that they used very high quality spine imaging, which is not always available in general routine clinical practice. So this study showed the importance of spinal cord involvement and how that is so critical in understanding disability, and identifies specific things to look for on spine MRI, including the number of focal lesions, the size of the lesions, and that diffuse indiscrete abnormality that we see, that hazy increased signal on the spine imaging. Finally, I'd like to mention a study by Dr. Sormani out of Italy. And she used a combined clinical trial data set. So this was data from 2 phase 3 fingolimod trials, so over 2,000 subjects. And she used this data to characterize the relationship between brain atrophy and disability progression. What she found is that in both the treatment groups and the placebo groups, those with the greatest atrophy at the beginning of the study were the most likely to have progression of disability over the course of the study. Also, those who had a higher risk for progression, meaning those who had more atrophy at the beginning, seemed to have the greatest treatment effect of the anti-inflammatory therapy, fingolimod. So this study shows not only how atrophy predicts future disability, which is something that we had a sense of before, but also demonstrates that those who are at the highest risk for atrophy progression had the greatest benefit from treatment with an anti-inflammatory therapy. So we had previously thought that those who had the most injury initially were most likely to have progression, but maybe not respond so well to anti-inflammatory therapies. But she actually found the reverse. Those who were at the highest risk for progression had the highest benefit of an anti-inflammatory therapies. Or to put it in other words, those with the most to lose had the most to gain by an anti-inflammatory therapy. This wasn't a presentation specifically, but there was a new funding that was announced for progressive MS at the ACTRIMS meeting. And this was announced by a group, the Progressive MS Alliance. The Progressive MS Alliance is a worldwide collaborative of MS societies that are focused on finding solutions to progressive multiple sclerosis. Their eventual aim is to provide $30 million of research funding over the next 6 years. This is the first stage of their funding, and the Alliance announced 22 grants across 9 countries. And the goal of these grants is to remove barriers to the development of therapies for progressive MS. The grants were in a variety of areas, including clinical trials and outcome measures, biomarkers of progression, genetic studies, rehabilitation trials, understanding the underlying pathology of progression, and developing new disease models at the benchtop to help us further study progressive MS. So this is just the start of a very large, globally coordinated research effort focused on progressive MS. We have never seen such a globally coordinated effort at targeting a specific facet of MS, in this case progressive MS, that we are seeing here with the Progressive MS Alliance. This group is growing, and I think their influence will be very important in the MS field. And I'll stop there.
Thanks very much, Bob. I had a question for you. How would you say you use spinal cord imaging in your progressive MS patients in follow-up? Do you image them on a regular basis or just with symptoms? Do you look at the cervical cord, the whole spinal cord? I mean, what are your thoughts on that?
I don't routinely image my progressive MS patients looking at the spine unless there is something that is concerning. So if they are progressing very rapidly, if they seem to have something that looks like a relapse but didn't respond to typical steroids, or if their symptoms are unusual, if they have a very large amount of pain out of proportion to what I would expect for bladder or bowel or weakness, then I would utilize imaging to make sure there isn't something else going on. The something else may be a disc herniation that's pushing on the cord, or it might even be active inflammation from MS that may benefit from anti-inflammatory treatment.
Very good. Dr. Lael, did you have any questions for Bob?
Yeah. Bob, I was just curious, you know, you've talked a lot about atrophy measures and how important those are in natural history studies and also in treatment trials. Any chance we're going to get those in the clinic anytime soon, or is it going to be this eyeballing sort of thing that we're all used to doing?
I think we will in the future. One of the tricky parts about atrophy measurements, and Lael, you've done research in this area as well, is that there's a lot of variability by just biologic variability, but even more importantly from scanner to scanner. We can make a patient's brain grow or shrink by just scanning them from one magnet to another, upgrading the software within the magnet, changing the pulse sequences. All of that can change the measurement of brain volume or brain atrophy, and can do that over the amount of 1 or 2 years worth of atrophy. So that adds a significant amount of noise. In clinical trials, things are standardized very, very precisely and very, very carefully so that any change in the scanner is accounted for in the analysis. In routine clinical practice, we often don't have that luxury. Now, that said, there are some efforts underway working with the imaging manufacturers to try to standardize what the pulse sequences are and what the expected impact different pulse sequences have on atrophy. And I think over the next couple of years, we may see that coming out and being utilized in MS practice.
I'm going to call on Dr. Wingerchuk to talk about neuromyelitis optica, advances in diagnosis and treatment. Dean?
Well, thank you very much, Alex, and it's a pleasure to participate in this course. I thank you for inviting me. My task today was to present and comment on some selected abstracts related to neuromyelitis optica, or NMO, from the ACTRIMS meeting in Boston. And I've selected a few that are relevant to both diagnosis and treatment. So the first two abstracts on the first slide have to do with diagnosis and to some degree the nosology and towards an understanding of the pathobiology of this disease. So by way of background, we know that neuromyelitis optica and what we term NMO spectrum disorders are strongly associated with a specific biomarker, an antibody against the water channel aquaporin 4. But we also know that despite advances in the technology that has allowed third-generation cell-based assays to be used now in routine clinical practice in the United States with very high specificity and about 70 to 75% sensitivity, we're still left with a group of patients that seem to have the same NMO clinical phenotype, optic nerve spinal cord disease, yet they are aquaporin 4 antibody negative. And this is an observation that's been made throughout the world in patients in clinics and patients who have different ethnic and racial backgrounds. The findings are really quite similar. So there were a couple of reports at the ACTRIMS meeting focusing on on some findings related to a different antibody, Mellen oligodendrocyte glycoprotein, or MOG, antibodies to MOG, or anti-MOG for short. And Doug Sato from Japan, working with groups in Brazil and Europe, has shown that in patients who have an NMO clinical phenotype, but who are negative for anti-aquaporin 4, roughly a quarter of them will have antibodies to MOG. And there seem to be some specific clinical and laboratory differences between these individuals as well. So, for example, they're more likely to have monophasic disease and more likely to present with optic neuritis and myelitis as that very first event in combination. They often have a more severe initial attack, but better recovery than the anti-aquaporin 4 patients. So this may sound like patients who would fit the more classic definition of NMO, or Devick's disease, as we also called it. So presentation with severe simultaneous optic neuritis and myelitis, severe attack, poor recovery, but at least in the amount of follow-up that's been done so far, many, not all, but many of these patients seem to have only that single attack. There was a second abstract presented by Probstel and colleagues. This was another European cohort. And remarkably, this group also found that about a quarter of these anti-aquaporin 4 seronegative NMO cases were MOG positive. And it should be noted that these groups generally don't find double positives. So the MOG positive patients are the ones that are anti-aquaporin 4 negative. And again, they found that this initial combined presentation of optic neuritis and myelitis was more common. Another demographic feature of this group seems to be that it has a relatively equal sex ratio. So the female to male ratio is roughly 1:1, which is very different from the anti-aquaporin 4 group. So seropositive aquaporin 4 NMO is overwhelmingly a disease of females, of women, with a ratio of about 8 to 9 to 1. So we think this is, it needs more validation, it needs more work to demonstrate that this is a real phenomenon. We also recognize that MOG antibodies have a somewhat checkered history in CNS demyelinating disease, but the current groups of investigators emphasize that the techniques that they're using, the anti-MOG antibody assay that they're using, is really much different than previous generations, specific for the conformation of MOG as it's presented as an antigen, and they believe it to be more likely to be a real and robust biomarker. If it is, then the question, of course, will be what this has to do with the pathobiology of the disease. Anti-aquaporin 4, aquaporin 4 is a astrocytic protein. We think of demyelination occurring in these patients as a secondary phenomenon, and that cohort of patients really has an astrocytopathy, and whether the MOG patients represent something different will be a very interesting story. In the next slide, I move on to treatment, and there were several abstracts at the meeting dealing with treatment of attacks as well as preventative treatment to try to reduce or eliminate attacks in established NMO. And a German group, they call themselves NEMOS, a multi-center group, presented a retrospective study of the large number of attacks and treatment cycles in individuals with established NMO to try to get some idea of the relative efficacy of individual treatment strategies for acute attacks, and also the likelihood of remission, or at least what they mean is recurrence back to baseline of neurological function. So as you might imagine, most individuals are treated initially with IV corticosteroids with various regimens. Most of these, however, had to move on to another treatment, most often plasma exchange, but sometimes intravenous immune globulin or cell depletion type therapies. So 40% of their cohort actually had 2 to 4 more treatment cycles to try to enhance recovery in these patients. You can see in the data on the slide that NMO attacks are often very difficult to treat. So the first line treatment remission rate was complete in only about 1 in 6 patients and partial in 60%. So, and after the final line treatment, so that is 2, 3, or 4 different types of treatments, the results were not a whole lot better. So the interpretation of this retrospective study was that many NMO patients experience relapses that recover incompletely despite some of the most aggressive sequential therapies. In some more detailed analysis they did, they thought that patients who had received plasma exchange may have had a better outcome, although in such a retrospective study you might imagine that there was selection bias amongst the individuals who received plasma exchange in the first place. But in general, there's this fits with other data that's been presented and published in different forms in the past, suggesting that plasma exchange is a highly effective treatment for NMO attacks and may in fact be superior to other therapies. In a second abstract presented by Aboud and colleagues from the United States, they looked at treatment of acute attacks in 85 hospital admissions, and they looked at recovery after methylprednisolone with or without plasma exchange. And they found that plasma exchange was again potentially associated with better recovery, but the limitations of this study again are significant because of potential selection biases. But they found that many of their patients did a little bit better than the prior cohort I showed, with 2/3 of patients who received plasma exchange and IVMP recovered back to their pre-attack baseline. They also observed an earlier initiation of plasma exchange seemed to be beneficial as compared to later initiation of exchange. And I think people who have experience in treating these types of attacks, and especially with use of plasma exchange, are now gradually moving towards earlier initiation of plasma exchange, so not waiting as long to see if the corticosteroids are going to work. And in my own practice, I certainly, if I look after somebody who has demonstrated a beneficial response to plasma exchange in the past, if they have another attack, I get plasma exchange moving as quickly as possible. I'll still reach for corticosteroids because they're so quick and easy to get started, but I would move right away to plasma exchange because there seems to be a consistency in individual patients with regards to the ability to respond to plasma exchange. The next slide outlines a summary from the group at Oxford looking at current standards of care for NMO relapse prevention. So you likely know that in the realm of immunosuppressive drugs that we often use to treat neuromyelitis optica and NMO spectrum disorders, there are no approved therapies. These are all therapies that are used because they have some effect on B cells or antibody production, and in retrospective and some limited prospective studies have demonstrated what appears to be efficacy, but we don't yet have randomized controlled trials, nor do we have very good comparative information about the relative effects of these drugs. The Oxford group has led an international effort to try to learn more about the effects of our current standards of therapy, in particular gearing up for some of the phase 3 randomized controlled trials that will be carried out or are already underway in NMO and novel therapies. So what's listed on this slide is a summary of benefits or possible benefits of oral drugs such as azathioprine, methotrexate, and mycophenolate, as well as parenteral rituximab. You can see that there's small numbers because in the UK they usually start by treating with azathioprine, and they simply are presenting before and after data, but they're using these data to try to come up with baseline event rates that will be used for design of future studies. And they've also noted that racial background influences disease course. So and this may be true for the response to treatment as well. So this is something that investigators will need to take into account when we look at the results and the analysis of the upcoming randomized controlled trials. We don't have very good treatment biomarkers in NMO. It's the topic of the next slide. We certainly have a very good diagnostic biomarker in anti-aquaporin 4, but not much in the way of exploring disease mechanisms and following treatment with biomarkers. So following patients and looking at the presence or titers, for example, of aquaporin antibodies doesn't seem likely to be very promising. But a group in Japan presented some results using a drug called tocilizumab, which is a monoclonal antibody that targets the interleukin-6 receptor. There's been a number of publications on the use of tocilizumab in NMO and NMO spectrum disorders, typically aquaporin 4 positive patients who have not responded to other immune therapies and who seem to have a remission induced by tocilizumab. So in this study, the investigators demonstrated that this monoclonal could reduce plasmablast numbers, and of course plasmablasts are cells that are producing the antibody, which is likely pathogenic. And they also noted an increase in CD56 natural killer cells, high natural killer cells, and FOXP3 positive Treg cells. So the purpose of showing this slide is not so much that this particular study is going to be the answer for biomarkers, but that the intensive immunologic study now of individuals with NMO who are being treated with some of these specific monoclonals is starting to finally provide us some targets to look at as far as therapeutic monitoring as well. And that's the end of my slides summary from the ACTRIMS meeting.
Thanks, Dean, for your comments. Bob, do you have any questions for Dean?
Yes, Dean, we seem to be learning a lot about NMO, and now there is the new terminology for NMO, the NMO spectrum disorder. Can you tell us a little bit more about that and what led to that new terminology?
Sure, Bob. So the current diagnostic criteria that our group at Mayo Clinic proposed in 2006 was the first to employ and to integrate the aquaporin 4 antibodies with the clinical and the radiologic information. And then very quickly it was recognized that because of the specificity of the antibody, that many of these patients had a spectrum of clinical and MRI features that went beyond involvement of the optic nerve and spinal cord. So after that, we had coined this term NMO spectrum disorders to describe things like, for example, intractable nausea and vomiting associated with area postrema or dorsal medullary lesions that was clearly associated with the antibody. And that began to expand the spectrum of this disorder. So here we are now almost in 2015, and frankly, those criteria from 2006 are well out of date. So we have completed work of an international panel of 18 individuals from throughout the world with experience in NMO research, aquaporin 4 assays, and clinical care to try to develop some new consensus criteria. One of the key things we've tried to clarify is the nosology. We've proposed merging the terms of NMO and NMO spectrum disorders, partly because of the historical background, partly to help continue focused research and differentiation of these disorders from multiple sclerosis. And we further stratify this category by determining whether or not antibodies to aquaporin 4 are present or absent. So, for example, we would state that a patient has NMO spectrum disorder with aquaporin 4 antibodies or without aquaporin 4 antibodies. And we did this purposefully to allow for future development or discovery of other potential diagnostic antibodies. So the slide I mentioned earlier about anti-MOG is one example. If validated, we may see the use of this category of NMO spectrum disorder with anti-MOG as well.
Thanks, Dean. And Alissa, did you have a follow-up question for Dean?
I do. Dean, what would make you change therapy for a patient with NMO? Would you only change based on a relapse, or do you find imaging or serology measures to be helpful?
Yeah, that's a great question and a very common one. I think the short answer is really relapses are the key to thinking about appropriateness of current therapy or changing therapy in NMO. There is some information from some studies suggesting that there is an association, a relationship between, for example, the titer of aquaporin 4 antibodies and the occurrence of a recent relapse. But many patients are rendered seronegative by immunosuppressive treatment if they were seropositive in the first place, and yet they continue to have relapses. And we don't think that it's very likely following aquaporin 4 antibodies is going to be useful. So other serologic biomarkers are being sought. Although many patients will over time accrue some new lesions on their MRI scan, it's not clear that that is a valid reason to consider changing treatment. Many of these lesions are small, subcortical, non-specific white matter lesions with no symptomatic accompaniment. So the approach is a little bit different than how we would integrate MRI information in treatment decisions for MS. So really at the moment it still comes down to the occurrence of relapses. We know from a variety of data that unlike MS, these patients rarely, probably about 1% to 2% of the time, develop secondary progressive disease. We think that means if we're successful with immune suppression at completely eliminating relapses, that we should be able to keep these patients stable. So we basically are looking for clinical relapse breakthrough activity.
Well, thanks very much, Dean.
The oral agents were once again hot topics at ACTRIMS. Several themes were seen in the abstracts this year, so I've grouped those into And I've grouped those presentations in a way that makes sense to me. First, the effect of fingolimod on brain volume loss was presented in a couple of different ways. Dr. Di Stefano and others from Italy presented a pooled analysis from FREEDOMS and FREEDOMS-2 in which the percent brain volume change in patients with no focal disease activity was evaluated for patients treated with fingolimod or patients treated with placebo. What was seen in both groups was consistent percent brain volume change in both groups, but there was clearly an advantage for patients who were treated with fingolimod over placebo, although patients in neither group had any relapses nor any new MRI activity during the monitoring period. In the second step, they presented a regression analysis of all patients from FREEDOMS and FREEDOMS-2. The unadjusted regression showed a difference between treatment and placebo as expected in percent brain volume change. When the regression was adjusted for new lesions, on-study relapses, and treatment, there was still a significant effect on percent brain volume change not related to focal activity. Dr. Haring represented a group from Novartis that evaluated continuous treatment with fingolimod through extension of FREEDOMS, FREEDOMS-2, and TRANSFORMS versus placebo or interferon at the end of the core studies. The time to reach brain volume loss of the placebo group at the end of the core study was delayed by 14.6 months for the FREEDOMS group, 13.6 months for FREEDOMS-2, and 5.5 months for TRANSFORMS for patients who continued fingolimod during the extension study. So what this tells us is that brain volume loss occurs throughout the MS disease course in patients regardless of treatment. Fingolimod appears to delay the brain volume loss independent of focal activity. It's not yet clear if this is neuroprotection due to fingolimod or just a result of controlling inflammation. Another theme of this year's conference was the effect of oral DMTs on lymphocyte counts. Dr. Comey represented a group that presented pooled data from phase 2 proof of concept, TIMSO, TOWER, and TOPIC trials. All randomized patients exposed to teriflunomide were included. There were 1,000 patients who received the 14 milligram dose of teriflunomide. 24.8% of these teriflunomide 14 milligram patients versus 12.6% of placebo patients experienced reductions in total lymphocyte count. The decreases in lymphocyte count occurred within the first 12 weeks, and 2.1%, a fairly low number, had lymphocyte counts in the very low range. Only 1% of patients in the teriflunomide 14 milligram group versus 1.4% in placebo experienced serious infections during the study. Similarly, Dr. Fox represented a group that presented pooled data from phase 2B, DEFINE, CONFIRM, and ENDORSE studies. All randomized patients exposed to dimethyl fumarate were included. This number totaled more than 1,100 for patients receiving the approved dose of dimethyl fumarate. Mean lymphocyte counts were decreased by 30% between week 4 and week 48. Most decreases occurred by week 24, and 8% had lymphocyte counts in the very low range. There was no clear trend in serious or opportunistic infections for patients with low lymphocytes, and patients with very low lymphocytes did not stop their study drug during the trial. What this tells us is that a small subset of patients do experience a significant lymphocyte reduction with teriflunomide or dimethyl fumarate. Most of these patients can be detected by 6 months of therapy, so very early on, before the FDA requires a repeat complete blood count for patients receiving DMF, but the clinical significance of this remains unclear. Shifting gears a little bit, another popular topic was oral DMT use for pediatric multiple sclerosis. The U.S. network of pediatric multiple sclerosis centers presented very preliminary data about their experience, pooled experience, using oral DMTs in patients under age 18. A database search identified 28 patients across 7 sites who received dimethyl fumarate, fingolimod, or both medications. 23 patients had used at least one previous DMT, mostly injectable agents. Lack of efficacy was listed as the reason for switch in 35% of the patients. Dimethyl fumarate was chosen more often than fingolimod, but the reasons for that choice were not elucidated in the abstract. GI symptoms were the most common side effect, and the relapse rate was 0.653 per patient year with orals versus 0.879 per patient year prior to the switch. What this tells us is that oral DMTs may be a good option for management of some pediatric patients with multiple sclerosis. This is not enough data to give us an idea of safety or efficacy in this population. A larger cohort and longer follow-up would be very helpful. And the next, pregnancy and oral DMTs was another very common theme. So first, the teriflunomide clinical development program presented their data from clinical trial patients. I think we're all very well aware of the pregnancy category X rating for teriflunomide based on animal studies suggesting risk for human embryo-fetal toxicity. In the clinical trial with teriflunomide, 70 pregnancies in female patients were reported. 26 resulted in live births. All were healthy. 29 patients elected to terminate the pregnancy. 13 had miscarriages. 19 pregnancies in partners and male patients treated with teriflunomide were reported. And of those 19, 16 resulted in live births, all healthy. Clinical trial and post-marketing experience with dimethyl fumarate was also reported. There were 45 pregnancies in the clinical trials of DMF and 135 post-marketing. There's very limited information about these post-marketing pregnancies. In the 45 pregnancies in the clinical trials, most resulted in healthy live births. The spontaneous abortion rate or miscarriage rate was very similar to the general population. So despite concerns from animal studies, early pregnancy data did not show teratogenic signals for the two newest oral DMTs. Still, patients should be counseled on risk and the use of contraception when using these medications.
Thanks, Alissa. Bob, did you have any questions for Alissa?
Yeah, so with the oral therapies, we know they're associated with low lymphocyte counts, and they develop over 6 to 12 months of after starting therapy. How low is too low, and when do we start thinking of changing patients off of the treatments?
So that's an excellent question, and it's very appropriate to clinical practice. Like many neurologists, I get nervous when I start to see lymphocyte counts below 200 per microliter. I don't have an absolute cutoff. The implications of low lymphocyte counts in patients treated with the oral DMTs is not the same as the implications in patients with hematologic or infectious disorders. That much is clear, but we have very limited experience in continuing medication in patients with low lymphocyte counts, and I think that there is reason for concern, although the number of serious infections reported is very low.
Okay. Lael, did you have any questions for Alissa?
Yeah, you know, it's interesting. We really deal with a lot of women of childbearing years, and it's always striking to me the number of pregnancies there are in the disease-modifying agent trials. What do you think we should be communicating most loudly to our women when we're actually starting them on a disease modifier in the clinic?
One of the most important things to communicate is that none of our medications are proven to be safe for use during pregnancy or when someone is thinking about pregnancy. I think the emerging data from the pregnancy registries is very encouraging and reassuring for patients who do become pregnant while taking one of these medications. The elective termination rate in the clinical trials for both teriflunomide and dimethyl fumarate was greater than 25%. That's a very serious decision for patients who become pregnant while taking one of these medications. And I think that we can at least provide them some data about their odds of having a healthy baby if they do become pregnant.
That's great. Well, I want to thank our speakers for a really great set of talks. I want to thank you for your attention. And I want to make sure that you do your CME credit and have a great day.